I am going to be talking about a lot of products, and I'm not affiliated with them in any way.
Very good.
All right. So we're going to continue on this same topic of advanced hemodynamic monitoring that Katie just spoke on. I'm going to highlight a few other things. We have very little overlap here. I think it's going to be a good talk. All right. Let's get started. So let's just talk about a little bit of introduction. So we all know about hemodynamic monitoring, but what does it actually mean? Just the bare basics. It means that you're going to monitor cardiac output and organ perfusion. And keep in mind, hemodynamic instabilities, underlying causes can really be broken down to three broad topics: circulating blood volume changes, cardiac function changes, and vascular tone changes. Okay, what's the purpose? Why do we want to do this? Well, we want to monitor stability among patients. And when we're talking about patients, we need to break them down into the non-critically ill versus the critically ill, because you're going to have different types of monitoring that you're going to do, of course. For a non-critically ill patient, just the standard monitoring of heart rate, mean arterial pressure, temperature, CVP, urine production, etc. Those types of things are usually standard enough, can give you enough information to see how your patient's doing. Now, when we start talking about the critically ill patients, the ones in the ICU, you're going to need probably a little more. You're going to still have your standard monitoring, of course, to give you the whole picture, but advanced monitoring is really the standard of care. It's going to give you cardiac output, preload, afterload, volume status, and most importantly, it's going to help you with trending parameters that can hopefully help you and your doctors taking care of this patient to really get a projection of where this patient is headed, so that you're able to intervene before they have any kind of harm. Okay, I thought this quote from Michael Pinsky from Critical Care 2005 was wonderful about talking about hemodynamic monitoring and its importance. What he has to say is, hemodynamic monitoring is a central component of intensive care. Patterns of hemodynamic variables are often suggest cardiogenic, hypovolemic, obstructive, or distributive etiologies to cardiovascular insufficiency. Thus, it's defining the specific treatments required. Monitoring increases in invasiveness as required as the risk for cardiovascular instability-induced morbidity increases, because of the need to define more accurately the diagnosis and monitor the response to the therapy. So what he's saying is that if we can predict the situation specifically for this patient by looking at all the kind of information that we have, especially with some of the advanced monitoring techniques, then we can do what we want to do, which is prevent organ injury. Okay, so what's the application? The application is simple. We just want to guide the medical management of these patients. And with that information, then we can do some therapeutic measures. We can do fluid resuscitation or de-resuscitation. Do they need volume or do they have too much volume? Do we need to put them on pressors instead? Do we need inotropes, etc.?
Is that really a word, resuscitation?
It certainly is.
Never heard. Have you ever? Anyone in the audience ever heard that word? Nobody.
Yeah,
nobody.
It's a word now. It's a word.
You have two hands, so I count that as two people. Okay.
Let's talk about, in order to really understand what these devices, how they're helping you know how to medically manage these patients, thought it'd be really important to do a little review on shock disease processes. So shock can be broken down into 4 different types. The one we're most familiar with is cardiogenic shock, because it basically has to do with the heart. Any sudden change in the heart's ability to pump enough blood to meet the body's needs. It can be caused by acute MI, valvular disease, cardiomyopathy, prolonged CPB times, post-cardiotomy syndrome, myocarditis, inotrogenic situations, pericardial disease.
Del Nido.
Yeah. No comment. But actually, the most common shock that is seen in these critically ill patients is hypovolemic. And that really has to do with, if you think about it, just the blood and the fluid compartments, what's happening with the volume of the blood. Is decreasing in the circulating blood volume is what's going to give you that kind of shock. It can be caused from trauma, uncontrolled bleeding, whether that's anticoagulation or something innate in their coagulopathy, burns, electrolyte imbalance, most commonly with sodium, and also acute MI. Then one that might be not thought about very much, but it's actually a very interesting category, I think, is obstructive. So that has to do with the circulatory system as a whole. So it'd be any obstruction in the great vessels or the heart. So some common things that could cause that particular situation: vena cava compression, tension pneumothorax, pericardial tamponade, or high PEEP ventilation. And then we have distributive. Usually we're just thinking of it in septic terms, but it is actually all about the vasculature and any pathological hypovolemia. So it's just a loss of regulation in the vascular tone or permeability. Are you leaking? 3 categories of that are septic, which, as we know, is a dysregulated response to infection, lactate greater than 2, and persistent hypovolemia. Also anaphylactic, which is, of course, a massive histamine response. And then neurogenic, when you have an imbalance between the sympathetic and parasympathetic regulation of cardiac action and vascular smooth muscle. Okay, this is actually something that I've heard a lot about, but I didn't actually know how it was done in the most basic terms, so I thought this would be interesting to talk about. So fluid responsiveness, we hear about fluid challenges, but I really didn't know exactly how that was outlined, so I thought this was kind of neat. So a fluid responsiveness is just a fluid challenge. There's many ways to do it. These happen to be 2 of the least invasive and most common ones that are done at the bedside. So positive fluid response would be a greater than or equal to 15% increase in the cardiac output in response to a fluid challenge, which is typically about 500 mLs. An intravenous bolus of fluid is given, and then you evaluate the response, just like Katie talked about. So a normal patient should produce a stroke volume increase, but shock patients will have a decreased rate of response up to 50%. So there's always a real danger of having fluid overload in these patients that are already have too much volume.
Yeah, if they're at the top of their Starling curve, and then
exactly.
you add more volume, you drop them off the other side.
Exactly. So it's really important, if that's the type of challenge you're going to do, that you determine if the patient is in preload dependent portion of the Starling curve, just as Joe said. Okay, and then there's also something called passive leg raising, which I've seen this, but I had no idea that this is what was going on. So it's just like what it says, you do a 45-degree elevation of the legs while keeping the head at 0 degrees for 3 minutes. And you're just allowing the blood to, drain from the lower half, and you're getting the volume shift there.
You really had not done that?
I have never done that.
Do you know how many times I've done that?
I've never done it.
Oh, my God.
Yeah, anyway. Yeah, it's great.
It's an ER tool, yeah.
So, of course, that's similarly done, but it's reversible. And it's only about, on an average, about 300 mLs. Normal patients will have a 10% equal to or greater than and cardiac output within the first 60 to 90 seconds. Now, shock or patients that have abdominal hypertension will have a decreased response. Of course, there's some dangers along with that, which increased intracranial pressures and risk of aspiration. Okay, I thought this was a wonderful graphic. So this breaks down shock. It's real easy to understand in the 4 types of shock, and then the things that you're going to see, what's happening, what part of the body is actually affected by that, and it just kind of sums it up really nicely. And just keeping in mind, when you break down shock to its most basic level, it's just an imbalance between the oxygen supply and oxygen demand.
That's a good slide.
Yeah, it's nice. Okay, So Katie talked a lot about this, but I thought this was also a really good graphic. It's just talking about invasive. It's comparing the most common ways to get some hemodynamic monitoring done, advanced hemodynamic monitoring. So it's invasive and non-invasive technologies. So you've got the most invasive, of course, being the pulmonary artery catheter, which again is the gold standard, but we've already been over, the kind of, if you have one, great, but you're not necessarily going to put one in every patient. There's too many risks. Then you've got your minimally invasive ones, which most of them rely on pulse pressure analysis, which we'll talk about a little bit more in a minute. You've also got your Doppler, which can be esophageal or transthoracic. You've got your bioimpedance or bioreactance, I guess it is, and then your applied Fick principle. Now, for the ICU setting in the operating room, you're mostly going to see the pulse pressure analysis or the Doppler. The other two, although there's a lot of promise with the bioimpedance, I didn't find a lot of ICUs that were doing that. And the applied Fick principle is also great, but too intensive for getting your calculations. So a lot of times they are just relying on these other things in those particular environments. Okay, here's another nice graphic where this is just kind of talking about where these particular types of technologies are used. So you can see all the way to the right, the ICU, for the most part, those patients are more critical, and so they're going to have the most invasive. They're going to have a pulmonary catheter. They're often going to have the pulse pressure analysis devices that are calibrated, but they also have some overlap in the uncalibrated ones. Then over in the OR, Doppler, I didn't see a lot where people were doing applied Fick, but this particular graphic says they are. And then the endotracheal bioimpedance says that's also another good place for it. And then over in the ER and on the floor, they're doing more of the non-invasive pressure analysis and possibly Doppler. All right. Okay, so let's talk about the one that seems to be the most common, especially in cardiac. And we're talking about technologies that use pulse pressure analysis or relying on the arterial waveform to get their derived parameters. So we've got the non-calibrated, or some of them are also auto-calibrated. There's one that is called ClearSight, and this is from Edwards. And the technology, or actually the device, is an inflatable finger cuff. And from that finger cuff, it gets arterial pressure waveform, and that's how it derives all of its parameters. Believe it or not, there's another one, and it's the next spin. And this is a company out of the Netherlands, and it is also an inflatable finger cuff. Now, they do have their own different complex formulas on how it's determining this stuff, but the basic idea is the same. They're both using arterial pressure waveforms, and they're completely non-invasive, just like a blood pressure cuff. Don't need anything else to go with those. Then you have your LIDCO rapid system, and it's using power pulse analysis, and you're putting in your parameters of your patient, age, weight, and those kinds of things to help it fine-tune that a little bit. Then you have your flow track from Edwards, which is a pulse pressure analysis again, and it is mildly invasive because it can also be calibrated. Actually, that's not true. PulseoFlex is very similar to FlowTrack, but it can also be calibrated because what they really like you to do is obtain your cardiac output from another device and then input that so you have a more accurate baseline. So I thought that was kind of interesting. And then you have your I'm not sure how to say this one, ESCCO, and it uses something called pulse wave transit time. So it's, counting the time between the different waves in the pressure waveform. Then you have the little bit more sophisticated ones that are calibrated, and you've got LIDCO Plus, and they use the lithium dilution. And that's, similar to just thermal dilution, but they're, instead of using saline, they're using lithium to measure, how quickly that is getting dispersed. Then you've got your, I guess it's Pico Plus, and they use transpulmonary thermal dilution. And then this is the new one from Edwards, because their old one,
Vigileo.
That's no more. This is the new one.
Really? The Vigileo's off?
It's gone. So we've got the EV1000, and it's called the Volume View. So it's their most complex, and it actually looks like it's the device that is going to use the most information to try to derive its parameters. It uses the pulse contour analysis and the transpulmonary thermal dilution. And I believe that just launched within the last year or something like that. It's pretty new. Yeah.
I'll be interested to see more about that.
Yeah. Okay, so here's what I think after we've talked all about this, kind of thought about these devices and, why we have them. What's interesting to us, especially as, ICU nurses and perfusionists, is can we rely on these when we have in-lane other devices that are, doing part of the circulation?
Vis-a-vis ECMO or VAD or something.
Or Impella or, balloon pump. And a lot of the, as I was saying earlier, a lot of the journal articles that I was reading did caution that you need to look at the big picture when you're looking at these numbers, when you have these other devices in. But I didn't find a lot of studies that this was their purpose. This is what they wanted to find out. But I did find this one, and I thought it was pretty interesting, even though it was a very small sample size. This was done in Sydney in 2013. They took all of their VV ECMO patients over 12 months that they were able to, match up, and it was only 8, but they did this study using the Edwards flow track, because that's what they typically had in their ICU available. And what they were looking at is the usefulness of the cardiac output monitoring and assessing alteration in oxygenation status. So can those numbers tell us what's happening if we see a dip in, saturations? Can we look at that number and know we need to go up on flow? Are we going to have a response to that? So they compared resultant oxygenation saturations in response to varying the ECMO flow as a percentage of cardiac output. Now, when they looked at the individual patient data, it really wasn't conclusive. It was kind of all over the map. But then when they combined them together and they pooled them, they did see, although it wasn't a direct predictor, it went along with the same trending suggestions that the clinician thought that she should do or he should do anyway. So they determined that they thought this was useful, and it was a success. When the ECMO flow was increased as a percentage of the cardiac index, cardiac output, the arterial saturations did increase.
With this device.
With this device, right. And the device was, they found to be useful and assisted the clinician in determining when ECMO flows were needed to go up and when they were just troubleshooting, minor episodes of arterial desaturation. Yeah.
So essentially, was it essentially a validation study that there was a cause and effect, that we did this? And this should happen when we do this. And in fact, that is what we saw.
Exactly.
So
but only as a trend, not statistically significant. Again, they only had 8 patients.
True.
But they did find that with all of them, once they were pulled together, that if they did see a desaturation, and they increased as a percentage of the cardiac output that the flow track was saying, that they did have the appropriate response.
Okay.
Yeah.
So, okay.
Kind of interesting there.
I think so.
Yeah. And I really wish I could find more studies on this, because I think this is a really interesting topic that, the more ECMO is increasing, the more these devices are becoming standard of care in ICUs. This could really be preemptive to helping perfusionists in particular, and nurse ECMO specialists when we start having those more and more, on trying to look at the patient and see one more piece of information before making determinations. Do we need more volume? Do we need this? Do we need more flow? Those kinds of things.
Well, I think those are you want to let me let you finish with your
let me just finish this. So obviously more studies need to be conducted, and we need them to be specifically targeted at these devices, whether it be VADS, ECMO, or even the balloon pump, so that we can really look at these, especially because there's so many devices on the market, and although they all use the same basic idea, they all have different formulas. So I think we're going to find that some are definitely more effective than others, and it's going to depend on the particular situation. Maybe some are more effective when it is, a hypovolemic type of situation, and maybe some are more effective when it's, something else. At worst, these devices provide valuable information and can help predict trends that may be invaluable to preemptive medical management of the critically ill patients. But again, just as you said, I think it's really important that you're not relying on this, non-invasive, for the most part, device to determine exactly what you're doing. It's just one piece of the puzzle to help you get a better idea of what's actually going on in the patient.
It's very good. And I do think, very good, by the way, very excellent. Both of them were excellent talks today.
Here's all my citations, because I know you can read those. They're super tiny.
Yep.
And thank you.
Yeah, thank you very much. So I do think that's why I scheduled this, is because I do think this is a topic that, again, it's one of those, it's not sexy, it's not, it's kind of hard, but I think it's a really important topic that we have somewhat accepted,
right?
I guess would be the term. Accepted, really, to some degree, at least my experience has been mediocrity in actual monitoring. So I have several questions, if you don't mind. Have you used any of these devices, the pulse contour analysis devices in the ICU in your clinical practice as a nurse?
I have. I used the FlowTrack when I worked in the trauma ICU. We used it routinely on our trauma patients, and we did not use PA catheters very often at all. And then whenever I've been working with CV patients, most of them had the PA catheters. And I guess the theory in the trauma patients was most of the time it's hypovolemic issues, because they're typically bleeding out, or they're septic. It's not very often that your trauma patients, though it could happen for cardiac contusions and things like that, they could have cardiac issues, but more often than not, they're a younger population. They, I'm trying to be sensitive and say that if they had heart issues, they typically would not survive their trauma, those sorts of things. So we used FlowTrack often because we were really looking for that stroke volume variation. And we would,
yes, I wanted to talk about that
we
too.
We would check for fluid responsiveness in them to kind of dictate our treatment.
Yeah, okay, so that brings up my next thing, and this is to everybody on the panel. In regards to these devices, when you used it in the trauma ICU, or when you used it in the ICU, have you ever used these devices at all?
I haven't.
You have no experience with them either? Okay, so I've got some experience with them as well, but even with just normal monitoring that we do, but specifically about this, then I'll ask Katie, did you have confidence in it? Did you trust it?
I did, as much as I trusted the waveform I was receiving. So you do the square wave test just like you would with a regular arterial catheter. And if the waveform was good and I could kind of sort of validate that with my non-invasive pressure, then yes, I would trust it.
Because how many times have we seen this, and this is to both of you, that the blood pressure looks horrible and everybody's running in there, something's wrong, and they're getting ready to resuscitate the patient. And they're sitting up eating Jell-O. Because
No, you always look at the
patient's
patient
just
first.
fine. Yes, exactly. How many times
You have to look at the patient.
How
That's
many
the key.
times does that not happen? And everything looks good on the monitor, but the patient looks horrible. Does that happen with? Have you ever had that actually happen?
Where the
Trust but verify. A good one from the audience.
which part, one way or the other?
Either way, where
Yeah,
the
the
numbers,
good or the bad.
the numbers were in no way reflective of what the patient actually was.
Oh, absolutely. Whenever a patient is turning septic, they go into a hyperdynamic state where their cardiac output and index is increased, and they're, you're
Their
like,
numbers all look good,
but their labs look bad and they just don't look right.
Yeah.
And so that's kind of your early stage before they go into full-blown shock. And so, yes, you'll see that. And then you'll also see it's kind of more inexperienced clinicians who will go in and freak out over the monitor, but the patient's doing just fine. So you do see both. What's really challenging is when you have somebody who's more inexperienced and they aren't recognizing when the patient is turning for the worst, but the numbers look good.
On paper, they look like
They look great, but they're actually really sick. And so someone who is less experienced may not catch on to that.
Yes, understand. Did you want to get a microphone? Yeah. There you go. That's even better because everybody out in the web world can hear your question as well.
Yes, with the clear sight inflatable cuff, how does it actually work? You were saying that it works kind of like a blood pressure cuff, but does it have to just inflate and deflate and stay deflated until you want another reading, or how does it actually work?
It works on intervals. So the actual monitor that's running it it could still be run off their new monitor, the EV1000, I think it is. It's just this would be one module of it, and it's set at, I can't remember the interval, but it is continuous. So it will do not continuous. It will do continuous points for trending. So it's inflating, and then whatever the interval is, 6 minutes, 2 minutes, whatever it is, deflating, and so you're getting these points to be able to predict the cardiac output. It can't, just one reading's not going to give you, what you're looking for. It really needs points, data points for the arterial waveform.
And not necessarily an absolute cardiac output, but is the cardiac output increasing or decreasing or staying the same?
Right.
That's what it's going to tell you, I assume.
Yes.
Okay, so the LIDCO, I have a lot of experience with LIDCO too. And of course, I was really an early adopter of it, and I really liked the device because you give the patient an injection of lithium, so at least you knew that you were doing something good for them. They would feel better afterwards if they recovered, if they survived, and you would, at the same time that you injected, you had the radial catheter connected to a pump that was pumping at a specific rate blood out of the radial catheter. So you gave it into the central line, and I think you could give it peripherally too. I don't think it mattered, but give it in a central line, let's just say, and then the amount of time it took before it came through the catheter past the sensor that read the lithium sensor, and said, okay, it took this long to go from injection to here, just pretty much like a thermal dilution, old style cardiac output. And then that is how it would calibrate. But now some people, and they used TEE. Of course, TEE is great for measuring cardiac output. Of course, that's truly the gold standard.
Right.
The PA catheter is the gold standard, I think, only because the PA catheter was the only thing that actually existed for so long. So it's kind of the default gold standard, but it's not a very good gold standard. You know what I mean?
Yeah.
So I think, right, we accept its inaccuracy, so therefore we trust its accuracy. That makes no sense, but that's, I guess, what we really do. But I liked the LIDCO more than I did the Vigileo. But Vigileo was made by Edwards, and Edwards was a very powerful company, and Lidco was made by a small company in England, and they really couldn't compete from a marketing perspective. So Vigileo basically just
Took over.
well, didn't take over, but never let them really gain the traction I think that they deserved. I think they were I think it was a better device. But again, balloon pump in, irregular rhythm, atrial fib, any of those issues, poor waveform, you couldn't trust it. But I wanted to follow up on what I think is again another topic we should discuss, and that is stroke volume and pulse pressure variation. So stroke volume variation and pulse pressure variation, and what those actually mean in terms of cardiac function, volume status, and all of these things. So do you have any, did you look at those when you did it? Did you look at stroke volume variation and pulse pressure variation to assess the patient, or just stroke volume variation?
Just stroke volume variation.
And because I think that's another interesting component to all of this. But it brings up patients on balloon pumps. And I'm going somewhere with all of these questions. There's going to be a point at the end of all of this. How many here have used the fiber optic balloon pump?
I have.
Have you used it?
I don't think so.
It is.
I don't like it.
Does anybody? You want to talk about
Somebody does, because they keep buying them.
I know, but it's horrible.
So you know what it does? It uses a fiber optic inside of the balloon, so you don't have to have a pressure transducer. So it's deriving all of that.
Pressure. It's deriving your pressure waveform from this fiber optic device. And so it does, because the old balloon pumps had a central lumen that you could run a transducer from, or draw pressures, or draw blood, or whatever it is you wanted to do from it.
I think this one still has a lumen, but
But it's teeny.
Yeah.
It's like, it's just enough to get the wire through, and that's it for insertion. But it's horrible. And when it doesn't work on the balloon console, it's a mess. But again, the balloon pump is being timed in automatic mode from the data being received from this fiber optic.
which is very finicky.
And yet the balloon pump, which can do harm, it's not a benign device. We kind of consider it now just to be an aspirin because it's used so much and it's been around for so long. But it can do some real damage.
Well, and it's especially concerning when you are in, surgery with a cardiac patient, and you put this in and you don't have a regular EKG. So that's your backup trigger. And now your fiber optic's not working. So now you don't have a trigger.
Right.
And it's real hard to fix.
It's real frustrating, very frustrating. Have any of you used NIRS, the near infrared spectroscopy, or the what do you call that thing that they put on the forehead?
Biz.
Not the biz, the other thing.
Cerebral oximetry.
Cerebral oximetry,
Sorry,
yeah,
that's what I
NIRS.
meant. Yeah.
Cerebral oximetry, where I've seen them put it in on the legs and stuff. Do either of you have that experience?
I've used cerebral oximetry where I came from. We used it on every heart case and tracked it, and but never seen it used anywhere else.
Do you have confidence in the device?
Yeah, well, if your baselines are good, when we first got it, we had a lot of problems with the baselines. The pads not getting put on before anesthesia, which then you don't have a real baseline, right?
Right.
But yes, actually, I do. We got a little bit of a on-the-job training with those as far as how it's related to being on cardiopulmonary bypass. And I have seen that, if you are out of range and your cerebral oximetry is climbing up there, it's a flow problem, it's a sedation problem. And as soon as you give those things, it drops right back down. So
Or a transfusion if necessary.
Or a transfusion is necessary.
Whatever the case might be.
Right.
So none of you have experience with seeing it in any other part of the body.
No.
Whether it be the, down in the in the lumbar area. Have you seen it? Have you used it at all? Because I've seen that too. So where am I going with all of this, these questions? I'm asking all of these questions about all these different things to sort of illustrate a point. And I brought it up earlier. Let me see a show of hands of whom at the panel or anyone in the audience who thinks that we do a good job of hemodynamic monitoring of critically ill patients today?
Is this a trick question?
No, it's a real serious question. I'm being really quite serious. Okay, let me rephrase the question. Does anyone here think that given the amount of technology that we have and where we are, 21st century, does anyone here at the panel believe that we do that we do not do an adequate job of really good, trustworthy, accurate, believable, dependable hemodynamic monitoring of our critically ill patients? I'll raise my hand to that one.
Well, I think that your point is correct with all this technology, but we still don't know, just to my point that I made, we still don't know how accurate these devices that we are putting on there are, one, and two,
On any given patient.
on any given patient, right?
In the lab, they're all perfect.
Well, that's what I would say.
Ideal.
On the ideal
Patient,
the
but-
patient who is not moving, the patient who
Right.
has a normal cardiac rhythm, the patient,
Right.
Who doesn't have atherosclerotic peripheral vascular disease, which is none of our patients who doesn't have.
Well-
there's so many
Right.
confounding factors.
Yeah.
Right. I just think that we have a lot of hemodynamic monitoring choices.
Sure.
But there aren't any of them that we can say, this is our holy grail. This device works every time on every patient, or works almost always on nearly every patient, or anywhere even close to it. I guess my experience in medicine has been, in the critical care arena, has been that, I've seen more problems associated with monitoring than necessarily nice, easy on patients who are sick. Not your aspirin overdose who's in the ICU that's otherwise, healthy. I'm talking about really sick people that we've never really figured out how to best provide comprehensive hemodynamic monitoring without being overly invasive, like TEE or something like that, but that is dependable. NIRS, you do the cerebral oximetry, there's that famous article out, patient or pumpkin, you put it on a pumpkin with a light in it, in the pumpkin like a candle, and it'll give you a reading. If you put it on a patient who's alive, it gives you a reading, and the range is this.
Well, but don't
if
you
you
think
put it on
that-
a dead patient, it still gives you a reading, and it can be normal. And if you remove the patient's brain and put it on that patient, you wait till they're dead before you remove the brain, but remove the brain, it still gives you a reading that can be normal. So if it can do that,
Well, what's normal?
can you believe
I mean,
it?
you're supposed to be using it as a trending device, not as a
Absolute figure,
Right.
absolute number.
Yeah, if your baseline was, 50 on your left and 57 on your right, you're watching that you are at least that or, a below and not above. But every patient, there was no hard number. Some patients had really low numbers and some patients started out really high, but that's just where they started. You just use that as your starting point. So are you saying that they had variation?
The pumpkin had variation.
Yeah, the pumpkin had variations.
The pump or
The pumpkin.
Pumpkin.
The pumpkin.
Yeah, the pumpkin or the.
Oh no, the pumpkin doesn't have variations, but it will give you a figure.
Yeah.
It will give you a range. Each individual
It gave you the
pumpkin
normal for the
would
pumpkin.
give you, but yes, it'll give you a range. Some were normal, some were abnormal, but no, the pumpkin didn't vary, so there wasn't variability.
Okay.
I guess unless the candle, was getting like lower and weaker or something. I'm assuming then it did. But the title of the talk really had nothing to do with the pumpkin. It more had to do with the concept,
No,
patient or
right,
pumpkin. It was
right,
just a
right.
cute twist on it.
Yeah.
But nevertheless, the point is that I still feel, at least it's my belief, that given our technological advancements, I don't feel advanced hemodynamic monitoring has caught up to where we are technologically. I think we still do things like, why do we still have this as a problem? Why are we still struggling to know if we can trust this blood pressure? Why are we still seeing it, just things like that? How do we still not know that we're delivering enough oxygen to the patient just by being able to look at a number on a monitor and know that that's right? Like, we want to measure continuous DO2. There are devices that will do it. Lidco is one of them. I think this EV 1000 or 100 or whatever, that'll do it as well. But it infers a lot of information. But why is that so hard? Because it can be wrong. Can you really believe it? Can you really trust it? And why not? Given what we can do today, phones, little teeny phones, all the stuff we do, and we're still measuring blood pressures like we did back in the days before Alexander Graham Bell invented the phone.
Well, I think specifically speaking
maybe not quite that far back, but close.
For the non-invasive or minimally invasive, because they're using an inline arterial catheter or something, they're deriving all of the parameters. Anytime you base a result on all derived parameters, you're going to have variability because it's not a real number. It's your best guess with the formula that you think gets you the answer right the most times. You know?
Yeah, that sounds, I agree, that is the case. I'm just trying my point though is I don't think that's really a good idea. I don't think that's great. I think we should know. I think we should be able to know.
What my point is I don't think you can have the kind of confidence that you want to have if you're basing all of your answers on a derived. You have to have something that is known for sure that leads to the next thing, like a math problem. You can only have so many variables, right? And sure, you can derive a few things, but if your end answer was from a derived that was from a derived that was from a derived, it can't be that accurate. And that's why it has to be,
inferred.
It has to be used as a trending device.
Triple inferred.
Trending device only, which was the caution in a lot of the articles that I read, that you need to remember, look at your patient, look at everything else.
Eyeball test is the best test of all.
Right, and in the whole picture too, even just looking at the basic parameter monitoring, pressure, urine, color of the patient, all of those sorts of things are real important, how you're going to determine this great advanced monitoring system that you're using.
So I got to tell you this story.
Oh, gosh.
So we want to see their reaction to this. This is a true story. So I was visiting somebody, and they were doing like out of the country mission type thing, and it was in a Spanish speaking area, and we had done a heart procedure. And we were sitting back in some room or whatever, and just chatting about stuff, the case, and everything went fine. And nurse came in and told them, we're really having trouble. They were doing anesthesia actually. They were having trouble with the blood pressure. It wasn't working right or whatever. And he said, "That's okay. I'll be there in a few minutes. That's fine. Don't worry about it." And a little while later, they came back and said, no, they were really having trouble with it. They can't get a good blood pressure. And, they're just having a really hard time with measuring the blood pressure. And they even, did a cuff because they had an indwelling line. They did a cuff and it's not reading either. They're really having a problem getting the blood pressure. And so he said, that doesn't sound good. So he said, let me get back there. So I went back there too and got back there. The patient had coded. The patient was full code. Had been code, and that's like 15 minutes later. But the blood pressure, they were having a problem getting a blood pressure because there was no blood pressure.
Right.
Oh, God. I was like, okay. I think I'll make my way to the airport now before the authorities get involved in this and get out of this country. So anyway, any final thoughts about all of this?
I would just say that the biggest thing is you have to look at your patient first. You can't just rely on one number and go off of that. You have to look at the total picture. You have to see what's tracking and trending with everything. And I think one of the things I would like to mention is that if you have somebody who the doctors aren't looking at the numbers that you're deriving from whatever method you're using, you really should question, should we still have this PA catheter in? Should we still use this flow track? Should we still, do we still need to look at this? If nobody's gonna look at the trends and treat accordingly, then you have to weigh whether your benefits outweigh your risks still. Because,
Well, that's the infection risk issue.
for sure.
Is if you're no longer using the data, take the line out.
Correct.
But if you're going to keep the catheter in, use the
it.
doggone data.
Right.
You know, I mean, that makes sense to me too.
And make sure that it's accurate as much as you can.
And therein lies, of course, the problem
That
is
is a
make
problem,
sure
yes,
that it's
but-
accurate. And
but
that's
you're gonna look at all factors on your patient, and you're
Right.
gonna look at all your numbers. And does the data match what you're seeing in your patient?
Right.
Does the data match what you're seeing in your lab values? Is the total picture coming together to give you an accurate assessment?
Yes. Can you
Yeah.
use the microphone, please? Because we can't hear you.
And is your training consistent in the ICU so everybody's getting the same information and using the technology the same way for each patient
Correct.
and interpreting the information the same way?
Correct. Yep, it's a good point.
That's a very good point. In fact, that's an excellent point, that the training needs to be consistent. I agree with
Yep.
that 100%. So, okay, so with that said, I think it's been an excellent session.